you'll kind of notice the theme that we've been talking. I've got a lot of physicians coming in and really excited about this conversation over the next few episodes around data, doctors, and leadership. Right now, I'm focused on the doctors and physicians in healthcare because I believe, and as others do, that the physicians should be leading.
In a value-based care, it's more about the outcomes. And you look at managed care plans. I mean, everybody has a value to that individual. And then how that money is spent and managed is a collaboration between the patient and the provider and the groups and things.
Well, thank you for joining us for another episode of the Leadership Lab. I'm glad you joined us. You'll kind of notice the theme that we've been talking. I've got a lot of physicians coming in and really excited about this conversation over the next few episodes around data, doctors, and leadership. And right now, I'm focused on the doctors and physicians in healthcare because I believe, and as others do, that the physicians should be leading. There was a podcast that I was listening to early this morning and really talked a bit more about how physician-led with the correct teams in communities is what we need to get back to. Now, for all my friends and others that have other ideas about it, I get it. Put your comments in. You can do whatever you need to do. But I do think that we need to have this dialogue, what's good for the patient. Because the one thing that is not lying is that the cost of healthcare is increasing exponentially. And so in order to stop that, we just have to do something differently. And so I love it that the physicians are beginning to lead the construct of this. If you've listened to a previous episode that I just did with Dr. Cozy, he made a comment and we kind of had some dialogue around that. I had an epiphany because I did not realize this, that when a physician obtains their degree, goes to residency, there's no any courses that teach them about healthcare economics. And I found that very eye-opening to me unless they go and pursue a master's degree or get their MBA or something. And so that could possibly be what is predicating this. And while I understand the premise of it, of patient care, it was a very interesting nuance. And I made a statement about that the physicians have just loaned their clinical experience to others away. And he corrected me on that and said, no, we gave it away, but we're taking it back. And I loved that statement that he made. And to that point, I'm excited to introduce my new guest, Dr. Beeson, but I'm going to call him Jeff because I've known Jeff a long time. I love his passion. When he talks, he's going to introduce himself to you. For you that do not know him, you'll guess pretty quickly where he's from. But Jeff, introduce yourself to the audience and where you're from and your background.
So yes, I am a confused soul. I'm from Texas, go figure. I was literally born into a public safety family. My father was in law enforcement and did some ambulance work back in the funeral home days, late 60s. During his time when he was drafted into Vietnam, became a medic and ended up running the ambulance service at Fort Campbell, Kentucky. So when he got out, was hired literally here in Hays County down the road to create and run a hospital-based ambulance service, and that was 68, 69, and we were there through 74. So when I was born, we lived in the parking lot of the hospital, and so that was my life. My older brother was a firefighter paramedic. My younger brother is a firefighter EMT. I was really passionate about the medicine, so started my EMT training in high school, and then got a nursing degree. That's my undergrad is in nursing, and then spent years as a ER, ICU nurse, working as a paramedic. I started doing aeromedical work in the mid-90s, and then ultimately went back to medical school later in life after about 11 years of nursing, and trained in emergency medicine, and then was fortunate enough to go right back, not only ER work, but go right back and be the medical director in Fort Worth for MedStar System, where I spent time as a paramedic. So it's been fun, full circle. I've spent the vast majority of my life in North Texas in the Fort Worth area. So from an EMT paramedic to a nurse, flight nurse, to physician, and so it's been a lot of fun. As I tell people, I'm I still maintain my paramedic licensure. I still have my registered nurse license, and I'm a physician. So I give myself orders. I argue back with myself. And since my wife is currently not in the room, I can be right for the next 30 minutes. So.
I love it. And are you a professor now too, or?
I'm an assistant professor at the UNT Health in Fort Worth in the medical education department. So I have many roles at the university, and through the past 9 years I've been there, I've been a chief medical officer to executive vice president health systems. So I've had many different roles, but I love I'm a part-time role right now. I'm diversified in various things, and I love being at the Health Science Center and working with the students.
And I think that's important because we're going to get into some of that diversification that you've done with your broad experience. And I think it's very interesting as I talk to a lot of physicians, whether they're within the EMS space or outside the EMS space, is I'm seeing a recurring theme that you guys are involved in a lot. And burnout's really real in healthcare, not just in the nursing space, the MS space. I was talking to a physician yesterday, and he was like, I'm always on the phone. Like his phone was there, and I could see that he was on call. And I'm like, well, how often are you on call? He said, more than I care to really think unless I go to vacation. And that was kind of a recurring theme. And that's not what we're going to talk about today, but it just reminded me when you were just listing the many things that are on your CV, and you just gave us the highlights. But thanks for joining, because I want to pick your brain about a few things as we look at healthcare. We've been doing that. You have been involved in Innovative. You have been one that has been on the forefront of it, a very active physician in that area, and an active physician also trying to understand the healthcare finance component and how it interrelates and correlates as well. And that's my background. I am not a clinician, so I'm going to the experts. And what I have seen over the last several years, because I've been doing healthcare payment policy work for over 20 years. And it's very interesting to me that we're regurgitating some of the same talking points that we did 10 years ago, 15 years ago, and there doesn't really seem to be a lot of traction. And the one thing that was an epiphany to me was a discussion around the use of blood. And the physicians really rallied in that way. And there was some impactful change very quickly around that. And I guess I had my own aha moment and said, you know what? We have a messaging problem with who is carrying the message. And so if you haven't checked out StoryBrand, go to another one of my podcasts or just Google that. There's a gentleman here that has gone on to effective StoryBrand that they really use in marketing and sales or whatever. But that is what we are doing in healthcare. We are selling what we do with the patient. Like, what is our value to the patient? So I want you to kind of take us into the process where your mindset is around. You've worked in the EMS system. That is all you've known. You worked in pre-hospital care. You've worked inside the hospital in emergency medicine because it's just one point of the continuum. But healthcare in general, not just us, are re-looking at everything that we are doing right now. So talk to me about a little bit about that before we get into what you're doing in this payer community side as well.
So I think for me, the interesting aha moment was in 2017 when I went back after being in some value-based care, went back to the University in Fort Worth and became the chief medical officer, and being responsible for the operations of our physician clinical practice, which is all primary care, vast majority primary care, ambulatory care. We don't have a hospital, right? We're in hospitals within the community there in Fort Worth. But all of our faculty, and then the struggles in the primary care world, and so you're doing the Lord's work, right? You're seeing the patients that need to be seen, and the system is literally, it seems like the system is fighting you, and that's really when I realized that it is, as physicians, right? We're in medical school where most of us are paying to be there. Then we become residents and we get our first paying job. And then in 3 to 4 or 5 years, we get out and instantly 3 to 4 or 5 times our salary. And we get out and we start working hard and we're making a good living. And then when you've been into it 5, 10 years, you realize you're working way harder than you did 10 years ago, but you're making the same and sometimes less money. And as I discussed this with other physicians, it was really an interesting thing. What other profession do you go into that you work harder and harder, and yet your income is the same or decreasing? And there's lots of variables in that, but that makes those of us start saying, wait a second, what are we doing? We're on the field actively playing a game, and we don't know the rules to the game. And so I think that's when those of us that have interest in, well, what are we doing here? Or in my case, trying to do something different. I needed to learn the rules of the game so that I could play the game, but play the game in a way that benefited me, the communities I served, the citizens that lived in that community, ultimately the patients. And I think that's where you're starting to see a significant interest because for many physicians, they're an employee of something, or even if they have their own physician practice coming out of residency, which very few do anymore, because of the lack, to your point, of business savvy and understanding those things. So a lot of physicians go back and get, an MBA or something pertaining to those. And then there's those of us that just are dumb and get lots of scars and learn, oh, I shouldn't do that. Let's do it differently. But I think it's the inquisitive mind. There's of those who just continue to work and realize this is what it is. I'll do the best I can in the environment that I'm working in. And then there's those like me that say, we have to do this better.
And that's what I like about
continue.
you, that your innovative brain, it probably never stops. That's why you're doing so many things. I can see it. Anybody that knows you very well knows that. But I think it's really important to let the audience know exactly why you are where you are. You didn't go back and get an MBA.
No.
You learned from your clinical experience. You applied that, whether it was your fire department experience when you were a paramedic, nurse. I think you took the combination of all of that, and then you started surrounding yourself with other people and started listening to them. That's kind of how our relationship started. You would pick up the phone and say, Asbel, how does this work? Which is what I love, because oftentimes you don't need to know everything about it. If you just need to know, where do I go get the right people? And that's what I'm doing. I'm not a clinician. I'm not a doctor. I have no desire to ever want to be one. But I know right where to go to get those experts in the room to say, you have the fortitude to do this. So let's kind of couple this together and figure out what's the best way to reform and make impactful change that keeps the patient at the center. Was reminded yesterday because we're doing a user summit in Laguna Beach in May. And we have 3 words that's kind of our tagline of the conference: data, doctors, and leadership, but through the eyes of the patient. And we did that 2 years ago. That was our mantra, through the eyes of the patient, as we kind of worked through there. And Dr. Kozer reminded me yesterday, Asbel, let's not forget. I'm like, that was our mantra. So we changed our title for our summit to be through the eyes of the patient, data, doctors, and leadership, because it's important. We've talked about data. You've been involved in that process. There are some great companies out there doing a lot of work with data. We've had them on our podcast. Go listen to that. But now I want to kind of explore that doctor thing coupled with the leadership. I've been doing a lot on leadership. If we would get to grace leadership and work in consensus and just agree to disagree on some things, because most of the stuff we do agree on in healthcare, and then bind together and get that patient involved with the clinician talking about how to move it, but it may mean that we do things differently. So I want to pivot real quick, because I want to spend some time talking about some of the novice concepts that you are involved in, how it started, because you've been working on this for probably 15, 20 years now. But let's talk about this whole nurse navigation process as people come into the system, how that works, and then how you guys are coupling this with the involvement of the payer community.
Sure. So when I was a medical director in Fort Worth, it was probably 2009, 2010, is really when I started to look at the high consumers of services. And that kind of led to, there was a lot of movement in the community paramedicine world. And so we literally in Fort Worth had a paramedic who had a back injury, so was doing office work. And I said, here's a dozen people, and these dozen people account for, it was over 300 calls in a year. I said, go find them. What's the problem? What's missing, and why do they keep relying on 911 for the solution? And so that was kind of the birth. And so from there, we began the community paramedicine program. We instituted a nurse triage in Fort Worth. It had been done in other cities. And being a nurse and being a paramedic, I knew that there was an impact that we could have in our communities for not the frequent faces that we see a lot, because that's a whole nother story. But, most people, first-time callers to 911 don't know what's going on. They don't know what to do. They called their doctor's office and it said, "Hey, if you have an emergency," they don't know. And so we respond the same to everybody, and that's part of the issue, I think, which is impeding progress in our services, our pre-hospital services. We pretty much give the same response in most communities to every single call. And so that's where we kind of started looking, how else can we do this? And there was a lot of movement. Brent Myers was in Raleigh at the time, and then there were things going on here in Austin. Ed Rock was leaving. Paul Hinchy came here. And so a lot of movement, a lot of us having discussions on those things. Which ultimately led to a meeting in Chicago where the whole concept was, in fact, is Jeff Goodlow from Oklahoma City, Tulsa, that said, really what we're talking about, is not just community paramedicine, but this whole integrated healthcare delivery model. Why do our EMS systems have to be staffed with EMTs and paramedics, right? There's lots of other clinicians, social workers, other things, and that's really what our citizens need in cases. Now, 15, 20 years later, we see the things coming out of ESO and the data showing that, we know from the point of a 911 call pretty much now what the hospital outcomes are going to be. And so we were precursing that, just saying we've got to do it different. We've got to figure things out. And in many communities, these types of programs are still going on today and making great impacts to build healthier communities. The struggle is they're not financially sustainable. There's no reimbursement for them. In most cases, there's no financial sustainability. And then unless the city or the municipality or the community wants to support these programs, it is questionable how much longer they can go on. And we have had model after CMMI, there's always some temporary thing, but there never seems to be a long-term fix. And that goes back to the earlier me learning about healthcare reimbursement and financing and how, this game is played. And what I've come to realize is that we're something new, right? And they all will agree that there's benefit and it's more economically sufficient, to your point of rising cost, right? But nobody, especially on the payer side, they don't know how to make us fit because it's either round or square. They don't know what to do with the triangle. And so that's kind of where we are today, and which leads me to Crosswalk Health, where I'm at currently.
So let's talk about a little bit about that, because I want to go into there because there's a lot of conversation happening right now where it's fear of change. Mm-hmm. And I understand that. I understand the patients here. We get concerned about if too much disruptive care, will it destabilize the system? What would that look like? I'm a crawl, walk, run guy. So, slow and steady wins the race, but we need to get to slow. And we're almost like just letting perfect be the enemy of good. We're trying to figure out the best solution instead of just the best time to start is now. Just start. Do a little bit slowly. And I think AI is kind of forcing that start because people are jumping into it, and it's going to have a lot of unintended consequences, I think, through the process. But ultimately, what will happen is the market's going to reset that a little bit. But you guys have been doing some things because you've been doing this for 15, 20 years. People are getting frustrated. They know it works. We're now seeing the longitudinal data that's coming out of ESO that is showing the premise and the hypothesis that you guys made 15 years ago actually is doing exactly what we thought it was going to say with empirical data, peer-reviewed data, not somebody's anecdotal data that we're talking about, but peer-reviewed empirical data that is showing that. And so how are you guys now taking that data? Because there's many of you guys doing this. Not many, but there's a few that are doing this. But Crosswalk is doing something that you've gotten involved in, and I just think these are that people need to pay attention to because payers are starting to pay attention to it, and eventually the feds will start to pay attention to this as well because generally these concepts get demonstrated at payer levels, and then there's aha moments that happen with on the federal side.
Well, I think the benefit of our Crosswalk Health experience, we're still an infant, right? We're established a little over 2 years ago. We went live on our first market almost a year ago. But it was the first time that really smart people spent a couple of years researching an idea and opportunity and then purposefully handpicked a team of, to your point, clinician innovators, disruptors, whatever you want to call us. And then
All of them.
some of the smartest minds in the value-based world, actuarials from the payer world, and put us all into a room. And I think many people will develop a solution and then go try to find a problem to apply it to. And we started with, what problem are we trying to solve? And we've been purposely building a solution that is applicable to almost any community. And the difference, I think, of us is instead of bringing a solution to your community, we're really facilitators of the solutions that already exist in your community. I mean, I had so many learning moments as a young physician medical director in Fort Worth when we started these programs. I mean, when we first started, many of the citizens and the callers to 911, 211, they don't really have clinical needs. Right. And if you believe and follow the whole health model, I mean, health care is a very small percentage of overall health and well-being. And we are even in EMS, right? We have a history, fire and EMS, history impeding progress. And I think that goes to your statement about AI and other things that are telling us what we know, but we just don't believe it. And so with Crosswalk Health, we're doing that. We're going into communities and putting EMS as the center. As I tell our partners and our communities we're at, if people don't know what Crosswalk Health is, we're successful, right? Because we believe that the sustainable solution is the EMS community. And if we can help the community, the healthcare systems recognize the value of the EMS system as much as public safety, a lot of healthcare, a significant part of public health, all of those, then we create incubators for sustainable solutions.
And so I want to go through, because we've been talking about this.
This episode is sponsored by Solutions Group Services, healthcare leaders' go-to source for maximizing reimbursement and inspiring innovation. At Solutions Group Services, our technology and consulting expertise help organizations recover millions in hidden revenue without disrupting their workflow. Through our flagship AI-powered tech product, Black Ink, we reveal the dollars stuck in insurance claims and give you the map to get them back. Because for healthcare leaders, they know leaving money on the table isn't an option for their organization. Learn more at solutionsgroup.com and discoverblacking.com.
And this came up in a conversation last week at, by the time people watch this, it'll be in several weeks ago, but with the Advocate Health conference, that they're doing a lot of stuff around this MIHCP stuff, and they did this in Chicago, and several of us were speaking about different things. And I'm a non-clinician, but I'm a healthcare finance guy, and I'm all about reformative. I'm a disruptor. Most people, I don't have a problem having hard conversations. I'm okay. We need to have that. That's what's going to move things through. But I brought in the concept, which they grabbed onto, around what we learned as a company when we brought in a marketing firm. And I actually did a podcast on this. I think it's one of the second or third one that I actually brought the principles of that company to give us kind of an introduction into what it means to message according to the story brand philosophy. And that is the hero guide philosophy. And it was an aha moment for me, Doc, because I literally internalized it, thinking that has been our problem in getting anything substantively done in our industry from a regulatory payer perspective, is because we keep ourselves in the hero. We can come in and solve all your problems if you do this, versus understanding I need to guide them to the solution, because the hero might be the mayor of your community. The hero might be your governor. The hero might be that state senator. That hero might be that patient in that community that's going to be your advocate for you. Because we can all say, oh, the hero is the patient. It absolutely is. But it depends on the audience that you're in, depending upon who you're going to guide and understand that. And once you begin to understand that, you begin to build your messaging around that. And so all of this stuff starts happening, and that's how the finance becomes, because I've got to identify the problem. And I'm going to guide you to the solution to the problem. So you have an aha moment that says, why in the world have we not been doing this? Versus focusing on it never gets paid, that nobody funds it, so we cannot do that. That sends us down a spiral. And I'm seeing more and more people they don't even realize that they're fine. They're changing their messaging. And all of a sudden they're having these wins. And that's what you guys are doing. So this is a concept I know that was tried way back 10 years ago. I mean, there was a company started because of this. I think you were involved in some of this stuff. And then there was some transitions through that. A lot of times it was so forward thinking that maybe it was a little too forward at the point in time, but it was kind of keeping up, and now we're there. And so you are doing some testing in this. I brought Dr. Montes on here to kind of talk a little bit about, I think he was in Indianapolis at the time, but he works with you guys now as well. And it's revolutionary what you guys are doing. So I want to talk a little bit about that, because some people are going to be thinking, what is Crosswalk Health? I thought they were on the payer side of things. How are they interrelated? Because I literally had a conversation with somebody on Monday that said, this group came in. I'm like, the best group you need to be in. What? I'm like, you know what? I'm doing a podcast with one of their docs. I'm going to have you listen to it, but you need to engage them. And it was revolutionary. It just seemed like this just seems too good to be true. And I'm like, it really isn't. It's where the system needs to go, is these type of concepts. So for those that are listening, because I'm telling you, you know it. We sit here and talk about it because we know it, but the average person that's watching this may think about something or like, oh, that's just pie in the sky, too good. I want you to kind of walk through what that model is, because it's a different type of model than some of the stuff conversations we're having.
So I think those of us that are, part of EMS, traditional EMS fire systems, what we need to realize is that we cover dirt. Right? I mean, if you call 911 from this side of the street, you get this city or municipality. But if you're on that side of the street, you get a different one. Payers don't understand that. And for my 35 years in EMS, it's very noisy, because whether you're a public, private, municipal, fire-based, third city service, right? We make so much noise talking about why our system is better than the system across the street. And I remember years ago, I was in the Capitol in Austin, and we were testifying on an issue, and I remember that the chairwoman stated that their perception from the legislative is they had the bill right because nobody was happy. Because even with every single one of us were up there saying how wrong it was, and she's like, well, we must have it right because none of you are happy. But you look at the health systems, the most competitive health systems will come unified on their mission as they are, in a sense, fighting the battle, which is, the war against the payers. And we have to realize that. So what we've done at Crosswalk Health is realized that the strength of EMS is in networks. And so how do we bring a bunch of different types of EMS systems together in a unified voice to show value to a payer? So where your system may cover this dirt and his system may cover that dirt, Crosswalk Health, we cover the lives, because we build the network of all of those EMS systems that then are able to add value to the payers and get the payers to raise an eyebrow and say, oh, wow, this is powerful. And there's many others that are doing things similar. But, we are not wanting to be in a fee-for-service world. We are really focused on a value-based world, and that's the benefit of the actuarials. And when you can monetize each one of these encounters and use data like ESO and other to show what the impact is, then the payers start saying, oh, wow, right? In their fear of if they create a benefit or have a partnership that excludes a subset of population, which is number one barrier to many of them initiating programs, because they can't provide a benefit or something that's available to a subset of their members. They have to have it for everybody, right? And so that is the uniqueness of Crosswalk Health in having half of our company from the payer world, and creating solutions to build healthier communities from data, to your point, right? There's no system that exists today that takes all of the payer data, all of hospital data, all of EMS data, and puts it all together, right? So there's things that we're having to build because they don't exist. On top of then getting the right people in the room to have the right conversations. There's times that the doctor needs to be in the room. There's times that the actuarials need to be in the room, and understanding that.
And this is the disruption that we're talking about is happening in healthcare. There's a lot of people just trying things different, new things, building things like that in networks, and you're getting payers signing on, and you're working with communities and 911 systems. And you made a statement, and I want to kind of bring some clarity. It's not in the outline that we talked about. I told you we'd probably go off a little bit, but you made a statement that I want you to give some clarity around, because this is a discussion that's happening even within our own communities, within EMS, within healthcare, within, if I talk to surgeons, hospitals, is you made a statement saying we really need to get away from fee-for-service and move to value-based. As a physician that understands the reimbursement arm, I want you to explain, what are you talking about? Because I will tell you that's going to give pause to a lot of people. It gives pause to me when I hear those things, but I've been hearing it a lot. And so it's like we need to explore this and try to understand what is going on. There's been a lot of discussion around value-based care. How do we do that? How do we incentivize? I heard it again today on a MedPAC commission meeting that I was listening in on, when they were talking about how do you align the Medicare payment and incentivize it appropriately, incentivize providers to avoid the gamesmanship that goes on. So there's this discussion that's happening. We can put our head in the sand, try to hope it goes away, but it's not, because physician community is really talking about it. And so once I hear physicians start talking about it that are there in the clinic care and they're advocating for it, I want to understand. So give me a little bit into your brain, Doc, about what you're talking about when you're saying we've got to get away from fee-for-service and move to value-based.
So, if you look at the history of ambulances back, Napoleonic Wars, 18th century, right? It was about movement. It's about moving somebody to healthcare. It wasn't until the 60s and 70s in the U.S. and when we really started having care that was part of that transport, right? So even today, EMS, the department lives under the Department of Transportation, NHTSA. It has to do with transportation. Our reimbursement is tied to transporting somebody with particular limitations, right? You have to transport, in most cases, somebody to a hospital, right? And so our whole reimbursement, the vast majority, I'm not talking in, nothing's black and white. But the vast majority is tied to reimbursement. So when I have people ask the conversation, what you're saying, so if I'm an ambulance company and I was reimbursed $5 million last year for transporting somebody, and if I went to a payer and said, give me $4 million instead of $5 million, but let me build the system differently to what my community needs and not building a system that's based upon transporting people to the hospital, almost every system in the country would do it differently, right? Because you're building what the community needs, not what the traditional system says that has to be. And so in value-based, in a fee-for-service world, it's I do something and then I get reimbursed for whatever that thing was. In a value-based care, it's more about the outcomes, right? And you look at managed care plans. Everybody has a value to that individual, and then how that money is spent and managed is a collaboration between the patient and the provider and the groups and things. And so it's much less regulated and really focuses on how the patients do versus what you did for them. There's a cartoon I use in a lot of talks that I love. Steve Barry was a paramedic. He probably still is in the Denver area. He used to do a lot of cartoons in gyms. And he has one of a guy being intubated, and there's like 20 things on the endotracheal tube. And, in the comment section is the paramedic's like, what in the world's going on here? But I love that because in EMS, we focus on what we do to our patients. I can intubate. I can give them drugs. I carry ISTAT. I carry blood, right? All the things that I do to patients. We rarely talk about what we do for our patients. And that's kind of the tradition of a fee-for-service to a value-based. Did I explain that?
Boy, that last story that you just gave, we talk about what we do to our patients and not what we do for our patients. That just inference there is huge to understanding the difference. Here's where I will tell you that the challenges kind of come in as we're starting to have the dialogue around what is it? Is it a marriage of the two? Is it a total deconstructing the system? What does that look like? We talk all about this is not a new conversation that we're having around reformative clinical care, but it is a new conversation we're having around reformative payment. And how do we marry the two? Because our system's almost been designed around the transport model. And that is what we were talking about even yesterday on a different podcast related to the same thing, because different perspectives are different from the physician community. And I think it's very, very important as we work through that component of it. And I won't leave the example that I gave yesterday because people can go back and listen to the podcast with Dr. Cozy. But I think it's just we're starting this dialogue, and it's going to get very, very important as we work through it. As we're kind of the last two questions I want to do, and I like to end my podcast with these questions and dialogue a little bit about it. And it's really relative to, in Dr. Beeson's clinical brain and what you've been doing in your communities and the impact that you've had on some of the reimbursement direction, because you have on some of this stuff. I mean, you were part of the MedStar model. You were the medical director at the time that was working through that. Was kind of, it made lots of headlines across the United States about some of the innovative stuff that you guys were doing there. And then you just matriculated over time into other areas. What is one or two things that you would say, if I did not have any impediments to getting something done, these are the top two things that I would like to see from the clinical and healthcare finance payment reform world? Not everything else, just what ties and dovetails into that.
Yeah, I think you asked earlier, said something that, like what keeps you up at night and worry. And my fear is, I've come to the realization in my life and my career, I got about 10 years left. And I think when it comes to physician burnout or any specialty burnout is when you work so hard to make a difference, and at the end of the day, the end of the week, month, or heck, the end of your career, you feel like you didn't make the world a better place. That's just a horrible, empty feeling, right? I love doing construction, and I love working on machines and cars and planes and things, because at the end of the day, I can see that it's different than when I came in. We don't often see that. As emergency physicians, I walk in and it's busy, and I leave and it's busy, right? I worked hard all day long, but I can't see anything different. So what keeps me up at night? 35 years into this, and I'm afraid in another 10 years that we're going to be having the same conversations that we've had for the last 35 years, and we're no closer to a solution. We can all agree that the system is non-sustainable. Something has to be done. We've said it for decades, and yet few of us are doing anything to change the system and try something different. We had a conversation a while back, and we talked about, you and I talked about the fact of changing behavior and how hard it is to change behavior. And you said something that I resonate with me, and I repeat it frequently, is we can't change behavior. So why don't we change how we respond to that behavior, right? That's where the opportunity lies. If I were the emperor of the world and it could change everything, obviously I recognize the value of what pre-hospital EMS, out-of-hospital care systems are, right? I mean, if you want to talk about a patient-centered delivery of healthcare, there are very few specialties that truly go to the patient. As a physician, the patient comes to me, right? They come to my clinic, they come to my ER. That is not a patient-centered delivery model. EMS in this country is the only healthcare that you can call 3 digits and they show up. My wife will clean the house for the cable guy to come. But yet, in most homes, if you're a paramedic and EMT, you've been to homes, you know that the house isn't picked up. Half the time, the people don't have clothes on, right? They are so welcome. We have a unique advantage in entry into healthcare. And I hope and pray that by the end of my career, that is stronger than it is when I started my career, that the world is a better place, and EMS has a sustainable future and truly recognized to what we can do to build healthier communities.
And I think we're seeing that recognized in that rural health transformation program that was in the One Big Beautiful Bill. And I think we have another opportunity if we are smart about it. Unfortunately, as we're watching some of the stuff that's happening in some of the states, we're probably going to waste some opportunities, but that's okay. You're not going to get it right in every state, but there's 4 or 5 states that are really doing some yeoman's work around this that I think will be demonstrable, a demonstration on what EMS can ultimately do. Last question for you is I want to understand your perspective as a physician and as we start seeing the introduction of artificial intelligence, and what are some of the positives that you think that's going to be, and then what the healthcare community from your perspective and your knowledge, because you've been doing this for so long, what you think they need to be aware of. And I'm really interested like in the clinical perspective and the patient care side of it on both sides.
Yeah, I am not an AI genius. In fact, I'm still not sure what the definition means. Everybody wants AI and everybody talks at AI, and I'm starting to realize
this is why I love your concept about that, saying I don't really know what it means, because that's a physician that is clinically skilled in this, that's got a lot of technology friends, and you're still trying to understand it. That's enlightening to me. I think that more resonates with more people than not.
Sure. I think there's learning algorithms, and there's things that I'm starting to learn more. And there are some amazing tools. I think from the simplest standpoint of things, when we think about, the documentation requirements to get paid for the work we're doing have become a significant barrier. And so there's a lot of innovation, there's a lot of tools coming out to help expedite and speed up documentation, to ambient listening to the rooms.
That's what I'm excited about.
Right, and things like that to help us, because it really becomes a battle. I mean, I tell paramedics all the time, you want to be a patient advocate, do good documentation. Because if you don't, you might not prove that the person needed the ambulance. They're still going to get a bill, but the responsibility is going to shift from the insurance company to you to the patient as the individual. So be a patient advocate and do good documentation, not for what you think it is, but what it could be. That's really the value. So I think there's a lot of tooling around there. There are great programs. In fact, I've seen a few presentations and read some stuff, especially in the call-taking 911 centers of AI listening, where the machine is actually quicker at picking up cardiac arrests than the human who's asking the question is. And so I think there is great opportunities to facilitate and expedite recognize life threats. On the contrary, or on the other side of it, I also think there's tools that we're seeing now that can safely recognize people that don't need an ambulance and don't need an ER and can safely go to an alternative location of care. So there's a lot of things like that. I think there is no doubt the fear is real about, people losing their jobs. In the last few days, I've had a lot of conversations about this topic, and I go back to my kids in the movie WALL-E, where everybody's laying around. And I mean, there is a world that if we don't get a hold of this, refusing to embrace it is not an answer. Letting it take over is not an answer, right? It's somewhere in between. And so I think it's continuing to learn. As much as every time you go to a ChatGPT or a Claude or something, it's learning from you, and we're learning from it. It is going to be interesting.
It's amazing.
The next 5 to 10 years are going to be way different than they are today. I don't know how they're going to be. I'm excited and I'm scared.
Yeah. And you know what? I would say that to the point that you made earlier, saying I'm afraid that 10 years from now, we're going to be having this same conversation. I don't think we will. And I think the reason why we're not going to is because AI is going to reveal stuff, because literally a lot of stuff's been hidden because of the data, because it's in so many disparate, people don't talk to each other. I think AI is going to be the revolutionary change that brings things to light that many of us may have had assumptions on that we were not aware of. And we're already starting to see it with some of the initiatives that the Centers for Medicare and Medicaid Services are doing, how they're looking to eradicate the fraud, waste, and abuse, and they're finding certain things. I found a very interesting report when they found that there was more hospice agencies in the LA area than in New York City. And then when they're finding out, come to find out, these are all, and I mean, we're just seeing it and so it's going to keep coming out, but it's these AI tools that are bringing this stuff, and now you're having a hard time, like, wait a minute, what else is out there? And so the president's budget that just came out, which everybody went on, the whole healthcare industry was like $100 billion to cut because of all these initiatives. That's pretty extensive in an area, and that to me is where I think, Doc, 10 years from now, I'm hoping we're not sitting. I hope we're doing something different, maybe on an island somewhere with our families doing something different. But I do think there's going to be a big conversation.
To that point, though, it's also scary in our instantaneous world today of data and results that people need to critically think about what they're reading and be able to ask questions and understand. Because it's really easy to put false information out nowadays. The machines are doing it automatically, and it's I never thought that public health things would be such a polarizing conversation. So, like I said, it's exciting and it's also scary. But we need to question everything. We need to critically think about things. We don't need to continue to perpetuate stories. As I tell folks, don't tell me what a research article says. Give it to me and let me read it. Right. So that's exciting.
Let me critically think through it. Let me critically think through it. Don't use, and that's where I get nervous about that AI will take some of the critical thinking abilities from our clinicians, from you, from a nurse, so what's that going to look like? A year from now, Doc, we'll probably be having a conversation. We'll see it. But if the physicians get in the forefront to begin to start leading the narrative, patients trust their physicians.
Yeah.
Patients trust their physicians.
I was in a meeting yesterday with a bunch of docs, and we talked about this. And one of the physicians said, "Until AI can remove a foreign body from a human orifice, I think I'm pretty safe as any other doc." So you never know.
Well, Doc, thanks for coming on the Leadership Lab. I'm sure we'll have some commentary on that, but I appreciate everything that you're doing and continuing to lead forward clinical care, keeping the patient in the center as well. So thanks for joining me on the Leadership Lab.